So we talked about ER-positive metastatic breast cancer last night in the keynote session, and we had 4 faculty who actually will be joining us for the next 2 modules. But we also will be joined by Dr. Virginia Kaklamani, who's the head of the San Antonio Breast Cancer Symposium. We're thrilled to have her here, and of course, San Antonio, the big event of the year in terms of breast cancer that just occurred. Virginia, we were talking last night about the wild scene that occurred this year when you guys saw the press release on Tuesday. Normally these press releases come out and then you have to wait 6 months or a year. This press release came out using a triplet therapy up front, and somehow you guys were able to get it together, get it presented, and discuss on Friday after. Any thoughts about how you pulled that off?
Data travels so quickly these days. You have Twitter, you have other social media, so waiting 6 months is unacceptable. It's unacceptable for patients, it's unacceptable for us as physicians. So it was a group effort. There's a lot of people that had to work very hard for many days to get this to work, but we're glad it worked.
So I want to welcome Sunil Gandhi. Thank you so much for joining us today. Again, Sunil is one of the FCS docs who's been working with us over the last few years, presenting cases to us. We're talking today about, we're going to talk in this first module about localized breast cancer. We're talking about ER-positive, triple-negative, as well as HER2-positive. Just kind of curious, starting out with the issue of ER-positive localized therapy. Sunil, any questions you have, any experience? One of the big controversies there is the use of adjuvant CDK inhibitors, particularly abemaciclib. Any thoughts or questions about that scenario for the group here?
Right. One question is, we used to use Ki-67 all the time. Now I heard that is being dropped off, but I'm not clear. All lymph node positives should be getting Ki-67, CDK4/6 or not. And in my experience, I've been lucky. I have few patients with CDK4/6 adjuvant, and they have tolerated it well. So I know it is lucky, but we manage diarrhea a little aggressively, and that is the main side effect of abemaciclib. So it works out good.
Kevin, can you kind of clarify the history of how this has gone through in terms of eligibility,
Sure.
Ki-67 in the beginning, and sort of where we landed today?
Sure. So, Monarch E was the study that led to the approval of abemaciclib for patients with high-risk disease. And for patients who had N1 disease, you had to have some high-risk features. And the majority of those patients had high-risk features, including tumor size or grade, things like this. And so when the FDA approved it, it was with the incorporation of Ki-67. When the European agency approved it, it was independent of Ki-67. And then the FDA now has gone back and removed the Ki-67 part of the label. So now it's just, high-risk early-stage breast cancer. And I think you're asking a really... I just did it. I didn't do it at all last night, and now I'm doing it. You're asking a very good question. Couldn't help it. Couldn't help myself. Starting off. So, I think that, the label says high-risk breast cancer. And I will say, in my clinical practice, I tend to, for my patients with node-positive disease, try to get abemaciclib. I just think the data, and we'll talk through some of those data, 2 years of abemaciclib, you're seeing this significant improvement in invasive and distant disease-free survival. At 5 years, I think it's meaningful.
So Virginia, one of the things that always perplexed me about this is, it's pretty common, it makes sense. You want higher risk patients in the trial, you're going to get answers earlier. But to me, once you establish a hazard rate, theoretically, you ought to be able to apply it to a lower risk patient and make a decision about whether it's worth it, side effects wise. That's the way we kind of evolved into adjuvant endocrine therapy in general, but yet here we're kind of sticking to what the trial did. Do you ever think that maybe patients at lower risk maybe it would be a positive risk-benefit profile?
I think they do, and that what's important from all of this data that has now emerged is that CDK4/6 inhibitors work in luminal A cancers and luminal B cancers, and we know that the luminal A's are going to have a lower risk. So it really has to do with absolute benefit versus relative benefit. So the hazard ratio is going to be the relative benefit. So if you have a 20-30% relative reduction. What is that absolute number? And if that absolute number is 2 or 3 percentage points, then as a clinician and as a patient, you have to make a decision. Is it worth it for me to take a medicine which has its own toxicities for 2 years for that 2 to 3% absolute benefit?
Of course, the patient can decide too whether or not it's worth it. Again, we were talking about that last night as well. Sunil, again, any questions in general about tolerability issues? You were mentioning the GI issues with Abema, and again, any issues that come up that you want to ask the faculty about with CDK inhibitors toxicity-wise?
Not only toxicity, if you don't mind, I wanted to ask, is there any trial on HER2 positive disease who are ER/PR positive, of course? Can we give them? Is there any trial or is that approved? And if tumor is 2.5 centimeter but node negative, would you give it?
So Joyce, any thoughts?
There was an adjuvant trial in HER2 positive going on, but it got closed because of all the other trials going on in the HER2 positive space, so it got closed. So we don't have any data in HER2, and I'm cautious in HER2 because when you get blocked CDK4/6 in HER2 negative breast cancer, one of the mechanisms of resistance is upregulation of HER2. So I wouldn't want patients with HER2 positive disease on CDK4/6 without inhibition of her family at the same time. So we don't have any data there. And then the node negative, I think as Virginia just said, if you had a super high risk individual, she's a T3, grade 3, all of the poor risk factors, we could apply that hazard ratio to her. We have the Natalie data, of course, with ribociclib, so I would probably go the ribociclib route if I could get it approved. If I couldn't, I would probably go with abemaciclib.
So, Kevin, it also made me think a little bit about the issue of hormonal therapy in general in HER2 positive disease, because like we always want to get separate trials for them and maybe they don't happen. How do you approach hormonal therapy in HER2 positive disease, from the adjuvant and metastatic setting?
Yeah, in soft text, for instance, which was the study that led to the utilization of ovarian function suppression for our high-risk patients, the majority of those patients had HER2 negative disease. But there's crosstalk between the estrogen receptor and HER2. We've even seen in the metastatic setting that, studies that really have some historic significance that, if you give HER2 target therapies along with endocrine therapy, it was better than giving HER2 targeted therapy alone. So, it's, including in the early stage setting, it's important to give both.
So before Joyce gets into her talk on HER2 positive triple negative, Sunil, you were telling me about an 82-year-old severely demented woman. Any case that starts out that way gets my interest right away. So Virginia, I'd like you to listen to this case.
So I practice in a retirement community, and of course Florida is a big retirement community if you see it that way. But in this patient comes, she's a wife of a ex-cardiovascular surgeon. Husband feels a mass in the breast. It was 3 centimeter, took it a little lightly, grew to 6 centimeter very quick, and big lymph node positive. You can easily palpate it. HER2 positive, triple positive disease. Now, 82, severely demented, you can't even ask her any questions. She cannot answer. She must be a very smart lady before, but not now. So question is giving chemo, particularly if I give TCHP, I think I'm over-treating. So what do I do? Do I just give like anastrozole and trastuzumab, or what else can I do?
And incidentally, what's the input from the husband?
Husband obviously wanted to avoid chemotherapy, but would be very willing to say, he knows me from social places, so he says, Sunil, whatever you say, I would do it. But then you have a little bigger responsibility.
Virginia?
This is tough. I don't think I would give chemotherapy either. I actually gave chemotherapy to somebody that was much less borderline, and she declined. And we tried to do this before we would do surgery because the surgeon said she's not a surgical candidate at the moment. And it was really very tough to see her declining, ending up in a wheelchair. So I wouldn't. But I would give dual anti-HER2 therapy plus endocrine therapy. These patients, you can keep them on this treatment for quite some time before they have any progression of disease.
So we can give anastrozole and probably trastuzumab and pertuzumab?
Sub-Q.
Sub-Q.
Yeah.
It'll be interesting to get some follow-up on that. All right, Joyce, let's talk about some of the data we have.
Okay, and I'll go through this relatively quickly because it's a lot of topics here. So we'll talk about escalating and de-escalating therapy for early stage TNBC, some disclosures, and I'll tell you about a patient that was a second opinion who I saw, a 30-year-old with germline BRCA. So she's an obese woman with a known germline BRCA mutation, a history of 10 years use of the levonorgestrel-eluting IUD, newly married, planning for pregnancy. Her mother was a 20-year ovarian cancer survivor. So she underwent her first screening MRI prior to wanting to become pregnant and was found to have a 1.8 centimeter mass, upper outer quadrant right breast, no adenopathy. Biopsy showed grade 3 TNBC, 90%, and moderate stromal TIL. So I thought, this is a good one. So she was treated with 4 cycles of preoperative docetaxel 75 and carbo AUC of 6. And she had gotten the first opinion of a preoperative dose-dense AC paclitaxel. And I said, gee, I'd like to avoid the doxorubicin, so let's try the docetaxel and carboplatin AUC of 6 with scalp cooling, good tolerability, working full time. MRI after 4 cycles showed resolution, so she went to bilateral mastectomy and implant reconstruction, had a path CR, and there was no tumor or fibrosis in the 2 sentinel lymph nodes, and so she was done. And so she's 2 years out now and is proceeding with her plans for pregnancy. So the goal there was to avoid the doxorubicin in her. But
Hold on before you keep going. Can you go back to the case for a second? I just want to ask you a little bit about it. So, germline BRCA1, and triple negative. Any thoughts about why she responded so well? Do you think it was the carboplatin?
Yes, I think it's the carboplatin, and the stromal TIL set her up for a very, very good response.
And what about PARP in a patient like this?
Had she been not a path CR, I would have been very interested. I would have been in the dilemma whether to give her AC post-operatively. That would have been a dilemma. I'm glad I didn't have to, make a decision on that, but I would have definitely considered PARP for her if she was not a path CR.
Sunil, I can't remember if you've ever used PARP. I think you haven't used PARP adjuvantly, or have you?
Not adjuvantly, no.
So can you talk a little bit, Kevin, about sort of the parameters? Joyce is saying because there's a path CR, she wouldn't use it. Germline BRCA, it's hard not to use it, but just kind of curious, when are the situations in an adjuvant, neoadjuvant situation where you would use a PARP inhibitor, which one, and for how long?
Yeah, so there have been studies about looking at or giving neoadjuvant PARP, but it's not something that's standard of care. Those were smaller studies. Based upon the Olympia study, for patients who have triple negative breast cancer and they have some residual disease, we give a year of olaparib. And for patients who have hormone receptor positive, HER2 negative disease, but higher risk disease, for triple negative, if you got neoadjuvant and you had any residual disease, you were eligible for that study. The things to look for, nausea, you can see some anemia. One of the concerns had been, are we going to see an increased risk of secondary malignancies like leukemia? But with the data that we have so far, there really hasn't been an increased risk for that toxicity.
Incidentally, you kind of glided past the neoadjuvant part, but there was a study where they had like a 50% path CR, and then I never saw anything else. Has it been followed up?
Yeah, there were some data, for instance, Jennifer Lynn from MD Anderson presented some data, and they were intriguing, and they saw some nice responses, but it also coincided around the time that we started to see the data from the adjuvant setting, and with the significant improvement in outcome, including survival. So that's really, I think, what impacted the trajectory of that.
All right, so Joyce, you're going to go through the NCCN guidelines here.
So had this patient been stage 2 or stage 3, she would have fit the Keynote 522 NCCN guidelines that we're all familiar with. And so we have now mature 5-year data from the preoperative paclitaxel carboplatin followed by AC with pembrolizumab in the stage 2-3 TNBC patients. And as you know, there was a 13.6% significant improvement in path CR, regardless on the right of PD-L1 status. We don't have to choose patients based on PD-L1 in the curative setting because the delta improvement in path CR is the same, so it's not predicting for benefit from pembrolizumab, but it is prognostic. The PD-L1 is prognostic. This is interesting. In Keynote 522, they defined full chemotherapy exposure as if the weekly paclitaxel, you had to get 10 to 12 doses to be fully exposed, and the same with the weekly carboplatin. If the patients got every 3 weekly carboplatin, it had to be 4 doses of the carbo, and they had to get all 4 doses of the AC. So that was full exposure. And you can see on the right that if they didn't get full exposure preoperatively, they benefited from the pembrolizumab the same, but they had a lower PAF-CR rate with both chemotherapy and pembrolizumab. So that was a cautionary note because we sometimes have to interrupt for steroids, et cetera. So we want to try to get that full exposure to chemotherapy in. So on the right is the interim analysis 6, the 5-year data, and it's really, really gratifying to see a 9% absolute improvement in event-free survival at the end of the day. And you can see the events are done, basically, in the treatment arm. Still 20% of patients recurring, but still that's a big, big advance. This changed my practice because I was a little bit waffly about whether a clinical T2, a small T2, definitely N0, really needed the risk of the pembrolizumab, but look at this 10% improvement in event-free survival. So I'm like, wow, I have to do it. And so we did learn from interim analysis 6 on the right that patients are better off having a PAF-CR on the top right from the pembrolizumab because their event-free survival is 88% with the PAF-CR with chemotherapy, 92% with the PAF-CR with the addition of pembrolizumab. So 4%, but then also for the patients who are not a PAF-CR, there's a 10% improvement in event-free survival, which is certainly gratifying to see, but it's very unfortunate to see how poorly those patients still do who don't get a PAF-CR. And so here's the non-anthracycline approach, the NEOPACT trial by Priyanka Sharma. 6 cycles of preoperative carboplatin, docetaxel, pembrolizumab. She was stage 1 to 3. Patients had to be node positive by biopsy, but there was a small subset, ER/PR less than or equal to 10%. And you can see on the left that is not a randomized trial, single arm, 120 patients, that we see the PAF-CR rate of 58% in all patients, and the confidence intervals were overlapping with Keynote 522. But I'll point out in the middle the ER/PR 1 to 10%, and you can see the 53% PAF-CR rate. So there are now 3 data sets that tell us that if patients are 1 to 10%, that they get the same PAF-CR rate with preoperative chemotherapy and checkpoint inhibitor therapy as do the triple negatives. So they should be treated, in my opinion. I think this is pretty well agreed upon with Keynote 522 if they're stage 2, 3, and an ER/PR 1 to 10%. So this justified the launch of the Scarlet trial, which has started. This is stage 2, 3, TNBC. 2,400 patients randomized to Keynote 522 or to the 6 cycles of docetaxel, carboplatin, and pembrolizumab with the primary endpoint of event-free survival. So very analogous to what we did in early stage HER2 positive, where we started off with anthracycline and we ended up with a TC-based regimen. So as we've just talked about, if patients have residual disease after preoperative therapy and they're a germline BRCA patient, or if they get surgery first and the triple negative, they're T2 or N1, we know that they're going to have a nice improvement in overall survival here. This is actually invasive disease-free survival at interim analysis 2. This is an 8% absolute improvement in event-free survival and a 3% absolute improvement in overall survival for the year of olaparib in the germline BRCA patients. We tend to give this with the pembrolizumab, even though that was not done in the Olympia trial based on the Keynote 522. And so we're aiming to escalate therapy for patients who are not germline BRCA. If they have residual disease, you can see with the arrow down there, they do poorly still, a third of patients still recurring within 5 years. And so the TROPION-Breast03 is ongoing of capecitabine with pembro versus the TROP2-directed ADC with the topoisomerase 1 payload datopotamab with or without durvalumab. So 2 questions being asked here. Or the Optimize RD trial, bottom right, the CAPE pembrolizumab versus sacituzumab with a pembrolizumab. And then if patients are a PAF-CR, can we de-escalate? Do they really need the checkpoint inhibitor in the adjuvant setting? And the Optimize PCR trials ongoing to stop the pembrolizumab versus continue the standard 6 more months of pembrolizumab if the patients are a PAF-CR. So then, just briefly, I thought these were really, really incredible data from San Antonio this year. We all know the Catherine trial for our patients who have residual disease after preoperative, now TCHP, TDM1 versus trastuzumab. And now at the 7-year mark, there's a 13.7% huge improvement in invasive disease-free survival, but still see that at 7 years, 20% of patients have recurred, these patients who had residual disease. There's also 4.7% improvement in absolute survival that's also significant. So these are really a big step forward. But what about that 20% of patients who still have, are going to recur in spite of our best therapies? What about adjuvant neratinib, the pan-HER inhibitor? Now, the extranet study was done before we had TDM1, before we had pertuzumab, but if we look at the group of patients, well, this is, first of all, the primary endpoint. It was only really positive in the HR-positive patients, but we see a 4.5% improvement in IDFS. This is in the adjuvant setting. But there were 295 patients who got preoperative HER2-based therapy, did not have a path CR. And then they got neratinib versus not, but this is only in the HR-positive patients. And you can see a 7.4% improvement in IDFS and, importantly, a 9% improvement in overall survival. A subset analysis, small numbers. But unlike the TDM1, which even in the Catherine, there's no decrease in brain mets in the Catherine trial, this neratinib, there's a definite signal. You see all patients there, 2.1% as their first recurrence of CNS versus 0.7% with neratinib. So we need the TKIs in the adjuvant setting, but we got to start with low-dose neratinib. As everybody knows, you got to start with 3 pills, then go to 4 pills, 5 pills, 6 pills. This is interesting. If patients can get 11 months or more of the neratinib in the extranet study, if you look at the pink, they will have on the right, the no path CR patients, there is a 7.4% improvement in IDFS and up to an 11.9% improvement in survival. So if we can get these patients to 11 months, we might as well take a year, they will really benefit greatly from the adjuvant neratinib. So I think that's justifiable because we haven't cured all these patients yet. So if they have residual disease, particularly node-positive disease, I definitely will give them the neratinib after the TDM1. So if patients are T1A, T1C, T1A, T1B, top left, N0, go to surgery first. We can, they're really truly T1A, T1B, N0. We can de-escalate their therapy to TH, or if they have neuropathy, TDM1. But we can escalate therapy if we find that they're really T2 or they are node positive. We can give them TCHP and consider neratinib if they really are high risk. We can do an axillary ultrasound. If they're negative, they can go to surgery. If they're T1C, N0, if they're positive by axillary ultrasound, they can be treated like a stage 2-3 and get the preoperative TCHP. And then if they're not a path CR, TDM1, and if they're high risk, HR positive, node positive, in my opinion, one could argue node negative, then the neratinib.
So a couple questions coming in from the audience, and I think Sunil has a case that would like to run by you. So Virginia, Daniel here in the room has a 65-year-old woman with a 9-centimeter node negative. He says ERPR negative. I'm pretty sure it's positive. HER2 negative invasive lobular cancer, 9 centimeters. Oncotype of 21, BRCA negative. Any thoughts about adjuvant chemo, hormonal therapy, abema, et cetera?
So this is tough because when we look at the data on the recurrence score, it's not a lot of patients that had tumors more than 5 centimeters. And so do you generalize it to other tumors? There's also heterogeneity. And so when you're looking at the sample of the recurrence score, are you really getting it from the most aggressive part of the tumor or not? Having said that, if somebody has a low recurrence score, then the chance of the chemotherapy really benefiting that patient is not very high, and that goes with lobular. That also, we don't see a lot of benefit from chemotherapy, but that's where I would incorporate a CDK4/6 inhibitor. Now, node negative doesn't qualify for abemaciclib, but as Joyce mentioned, she does qualify for ribociclib, and that's probably what I would do.
So, yeah, interesting case there. And, we were talking last night about an advocacy group contacted us. They're advocating for lobular cancer, and they're like, where's the research on our disease? And everybody goes, oh, you're ER positive, but that, lobular is differentiated, but I guess we'll just sort of see where that heads. So one other sort of relevant follow-up question, Virginia, from Charles, who says, if you're going to use abema adjuvantly, do we still need to use an AI for 7 to 10 years, or can we go with 5 years?
The quick answer is we don't know. But I would use, I typically do a genomic assay, the breast cancer index, that has data looking at long-term benefit of endocrine therapy. And so I make a decision based on 5 or 10 years or 7 based on the BCI score.
So Joyce, why don't you listen to Sunil's case, his 45-year-old lady with triple negative, BRCA negative, 5 centimeter lymph node positive disease. What happened there, Sunil?
Yeah, so she's 45, BRCA negative. So we gave her Pembro, and initially we gave like paclitaxel and carbo, and then doxorubicin and Cytoxan with Pembro. But she had persistent disease on surgery when she went to surgery. Now my questions are like, giving capsaicin into this case, how much does it really add? Or what is the real good way to treat this lady,
Yeah, we definitely need to, those trials I showed, with bringing in the sacituzumab and the datopotamab, we're really looking forward to seeing non-cross resistance. But yes, I would treat her with the 6 months of the capecitabine, in the CREATE-X, but also there are 2 meta-analyses of capecitabine in the adjuvant setting that actually do show a survival advantage. But but there's also these data that show it's really the non-basals, not the basals, and so we don't use that in practice. But I think about that, quite a bit. That maybe, but we don't have a way to differentiate that yet. So we need these trials that are ongoing. But I would give her the cape with the pembrolizumab because I think that's really all we have for her right now.
Okay. Joyce, what are you doing if they have a PATH CR?
If they have a PATH CR, I just finish up the pembrolizumab right now.
Are you ever tempted to not use the pembrolizumab?
I have a low threshold. If there's any question about immune-related adverse events, I stop. But I otherwise keep it going, per 522. But I have a low threshold to stop.
Kevin, just to throw it in here, because we hear more and more about cell-free DNA in general. Do you see cell-free DNA coming into breast cancer?
Eventually, yes. I would say every week in clinic, this is coming up. Every week. In particular for my patients with hormone receptor positive, HER2 negative disease, I think the issue right now is that it is prognostic. We don't know if it is predictive, meaning if you change the therapy, it's going to change the outcome. I think that's the major issue that we're facing now, and there are trials that are addressing this.
So, Sunil, you're also telling me about you had a patient who started out HER2 positive, gave her neoadjuvant THCP, and she turned HER2 negative?
Yes. And that's I have personally never seen that. So I was surprised. This patient comes like a standard triple positive breast cancer and used neoadjuvant TCHP. Goes for surgery, patient comes back, patient still had like 2 centimeter mass. And now they are saying it is HER2 negative, ER/PR positive. So what I was wondering is 2-3 questions. How common is that? Number 2, should I treat her like TDM1 or should I treat it not? Okay, and abemaciclib? I'm kind of lost in this case.
Well, and not to mention, Virginia, the real problem is what we're hearing from like GI people and people outside of breast cancer, because when they repeat, if it's negative, they stop using her therapy. And we're like, well, they don't do that in breast cancer. But you tell me, what do you do?
So there's data from Catherine that addressed this and showed that even patients that initially had HER2 positive tumors and then at the time of surgery, those tumors were found to be HER2 negative, benefited from TDM1. And this is a little surprising. The question is this a heterogeneous tumor? Is this really the clone of HER2 that gets destroyed by the anti-HER2 therapy and what's left is the clone that's not? It's unclear, but I continue TDM1, or actually I give TDM1 for these patients because of that Catherine data.
Joyce, any thoughts about this? Again, I really wonder. I hear, again, the GI people. I know it's a different cancer and all, but it's just hard to hear you say one thing and then you go to them, they're doing something else. Do you ever stop giving her therapy?
Well, twice a month, I have to send a HER2 specimen of tissue to Dr. Mike Press, because in every single neoadjuvant trial that's ever been done with HER2, 20% of the time, there's a wrong interpretation locally of HER2, 20%. I find overcalls all the time, and in the HR positive, you get weak HER2 amplification, and I'll see a 1 to 2 plus and a low level of HER2 amplification. I'm like, I don't trust it, so I send it to Mike Press all the time. Most of the time it comes back negative. And this is very important for this patient because of the abemaciclib question. So I would send both specimens to Mike Press, and insurance generally covers that second opinion. Not every plan does, but most do. I sent it to Mike Press at USC. He's got a big service lab. It's easy for the pathologist to find it online, get the form, send it in, very easy. And you find out because you got to know, because he says that true heterogeneity is like 2% of breast cancers. He really doesn't believe that there's true heterogeneity. These are really low level, but they do exist. They do exist, but they're very rare.
Yeah, I got to do a think tank with a bunch of pathologists and straighten this whole thing out, although I think it's probably impossible. Sunil?
Yeah, I got fish testing done on that just because I didn't trust it either, and it was negative. So that much I can tell you. Now, it was done in, I think, Quest Lab or one of those labs. I don't remember Quest or LabCorp, but one of those labs. But it was tested negative.
The residual disease.
That was at surgery.
Yes. But I go back to the initial biopsy too and send that off to Mike Press.
So it may not be HER2 positive.
Right.
Huh? Ah,
Right.
okay.
So-
That I did not think.
So I want to go to a special feature where we're introduced into this, but also to mention that we want Sunil to be the RTP narrator, because we love his voice. You think he'd be a great narrator. Anyhow, so we thought we asked Virginia, who's the head of the San Antonio meeting, because we thought we could just kind of add a little bit. We'd love to hear her input in general in terms of what happened in San Antonio. But we picked out a couple things to ask her about that we weren't sort of planning to cover that I just thought were interesting. This is part of the year in review. They have I don't know how long you've had that highlights thing up there, but it's very cool. There's a great, is that new?
We've probably had it for 10 or so years.
Oh, really?
But it's one of the highest attended sessions.
Yeah, I didn't even know it was there. It's a really incredible thing on their site. Virginia does, these are slides from sort of the highlights of the year that Virginia did. And that's really cool stuff. I just picked out a couple things. I've always been interested in this issue. Does lifestyle actually have some impact in terms of cancer progression? I've always been curious. It's been looked at in various cancers. Any thoughts about this paper that was presented this year?
Interestingly, the data in breast cancer shows that losing weight and getting to a normal weight is as beneficial as adjuvant chemotherapy in breast cancer. And this is easy for all of us to be sitting in a room and telling a patient that they should lose weight, but it's very difficult for them to actually do this. And now we have weight loss medications that are becoming very popular, the SGLT2 inhibitors and so forth. So this is going to be a very interesting era. So this was the Be Well trial where patients with stage 1, 2 to 3 breast cancer were randomized to either just education or a telephone-based weight loss intervention. And what you can see is that the patients that were on that weight loss intervention actually lost more weight. And the question is that 4.8% of weight loss in 12 months important? And the answer is it is. Even a little bit of weight loss goes a long way when it comes to improving somebody's survival. So this is, again, one of the ways to do this. There's so many other ways. I think we're going to be seeing these drugs being used in breast cancer actively. We know that they decrease the risk of cardiovascular disease, decrease the risk of renal failure for our diabetics and non-diabetic patients. So these drugs are probably coming to breast cancer as well.
You think they're actually going to be studied in randomized trials?
I sure hope so.
It's going to be really interesting. Another thing we want to ask you about, Joyce last night presented a case of a patient. Turns out it was actually, the patient was a psychiatrist who interrupted her adjuvant endocrine therapy to become pregnant about 5 years ago, the so-called positive strategy that was presented at San Antonio the year before last. And we saw an update of that. And actually, tragically, Virginia, you weren't there last night, but Joyce's patient relapsed after being taken off hormonal therapy, which of course, might have happened anyhow, but very difficult situation. Can you kind of summarize what was looked at here? Ann Partridge from Dana-Farber really led this effort, what they presented initially, what they presented as an update and what sort of the take-home message is here from this really landmark study.
Absolutely, and I wonder whether cell-free DNA will be important in this patient population where they're contemplating stopping endocrine therapy, and would they do that and try to get pregnant if they had positivity?
And
But-
your patient was not high risk either.
No, she was on the lower, medium risk, yeah.
So
No
this is
negative.
an interesting effort, and it started from retrospective data suggesting that patients that became pregnant after breast cancer diagnosis actually had a better prognosis than patients that did not. And we were always thought it was a bias because the patients that are going to get pregnant are the healthier ones. So this was a prospective trial. It was not a randomized trial by any means. Patients were on endocrine therapy and were able to discontinue endocrine therapy for 18 to 30 months and then try to get pregnant. And so what they showed was that these patients actually did pretty well, and they matched the patients with similar patients from the SOFT and TEX trial. And what you're looking at on the right hand of the slide is that the outcomes were very similar between the patients that discontinued their endocrine therapy, some of them got pregnant, and the patients that were on SOFT and TEX. So very encouraging results for our patients. And what obviously I don't think we needed that trial to see was the fact that the younger the patient, the higher the success rate of getting pregnant, and patients couldn't be on the trial if they were over the age of 42, so there was obviously a much younger patient population, but the younger patients had a higher success rate.
But 74% of them did get pregnant. It was
Exactly.
amazing.
Exactly. And then the other thing that they looked at was what is the chance of pregnancy with different methods, and what you can see is that patients that had cryopreservation had a much higher incidence of pregnancy, and obviously the age comes to play here as well. And one of the things that we always wonder is if we're stimulating their ovaries and giving these patients hormones to get them pregnant, is this making an impact in their breast cancer recurrence? And what you can see here is that the outcomes are pretty much the same whether patients did or did not have ovarian stimulation, which I think is extremely important and reassuring data for our patients. Again, when looking at patients that after enrollment had ovarian stimulation, you're seeing the outcomes, and the outcomes are very similar between the patients that did and the patients that did not. Very small numbers though, so please do keep that in mind.
So I'm curious, Sunil, have you ever, you mentioned you lived in a retirement community, so I don't know how many younger patients you've had, but have you ever brought up this issue to a patient or had a patient ask you who's on, planning to go on 5 or more years of endocrine therapy, the idea of stopping therapy to become pregnant?
To be honest, not pregnancy as an issue that has come to me personally. That my patient asked. I see more older patients, but I have seen 40, 45-year-old women, but they don't think about getting pregnant at that age that much, so not really.
All right, well, let's talk about the data. We've been talking about ER-positive breast cancer and particularly adjuvant CDK, and Kevin's going to review some of the data.
Great. So this is a patient case, 65, postmenopausal, grade 3, 1.5 centimeters, PR strongly positive, HER2 1+, status post-lumpectomy, sentinel lymph node biopsy. She has 2 of 3 lymph nodes involved. She undergoes systemic imaging. It is normal. Her oncotype returns with recurrence score of 21. What systemic therapy do you think about for her?
Before you go on, I know, Sunil, one of the things that you brought up to me was the issue of axillary dissection. Maybe you can verbalize your thoughts here.
Yes, I have this question I couldn't get answer on my own, but it is now standard. Everybody goes for sentinel lymph node biopsy, and at least in my community, practically nobody gets total axillary lymph node dissection. So now I have a patient who had 1 or 2 sentinel lymph node positive. There are many studies which say that all oncotype DX and everything helps, but if it is more than 4 lymph node, oncotype DX should not be used. I don't know. 1 or 2 sentinel lymph node positive, does it mean there are 6 lymph node positive or just 1 positive? So if I go oncotype DX and say it is low or intermediate in my postmenopausal woman like this, would I give her adjuvant chemo? I should not. If I don't give it, if she has 6 lymph node, did I undertreat?
And Kevin, I think I remember there's an editorial that addressed this in the JCO. Also prognosis, if you have 4 or 5 positive nodes that you don't know about. Any thoughts about Sunil's question?
Yeah, in Responder, about a third of patients had sentinel lymph node biopsy only, and it was one of those things that we stratified and looked for in a prospective way to see if there was a difference between those that had an external lymph node dissection or those who had a sentinel lymph node biopsy alone. There's no difference. And it also just further raises the question of whether for our postmenopausal patients, whether ultimately we should be utilizing genomic assays to help indicate prognosis, and because we don't have data for N2 or higher disease, and there's some conversations that are going on internationally to think about looking at those patients.
All right, let's take a look at some data.
All right, so we're initially focused on some data that were presented at ESMO in San Antonio that looked at the role of IO in hormone receptor positive disease. So these are data from the 75L study. That was a study that was looking at nivolumab, where patients received taxane followed by anthracycline. Patients needed to have high risk disease, including grade 3 disease, or if it was grade 2, that population that Joyce had already mentioned, ER 1 to 10%. Again, this is all neoadjuvant therapy. And what we saw from this study, this is just the population of patients. You can see the majority of patients had grade 3 disease. About 50% had stage 2 disease. For those who had a Ki67, most patients had a Ki67 that was 20% or greater for those who had known Ki67. And the vast majority, 80%, had node positive disease. And what we saw from this analysis is that when we look at PD-L1 expression by SP142, if it was high, meaning 1% or greater, that delta in terms of the benefit of achieving a PCR was higher. And this is different than what we've seen in triple negative breast cancer, where PD-L1 status is not an indicator for the benefit of IO. This was seen in this study and is also seen in the other study that I'm about to talk about. The other thing that was seen is that for those patients who had higher stromal TILs, as Joyce also had mentioned, that seems to be an indicator for response. But it can also be an indicator for response to chemotherapy. So in Keynote 756, these are patients who received taxane followed by anthracycline cyclophosphamide, again, neoadjuvant study. These patients had centrally confirmed grade 3 disease. Again, we're talking ER positive, HER2 negative disease. And then they went on to surgery. And then they also, if they received IO in the neoadjuvant setting, they continued in the adjuvant setting. It's worth mentioning in this study that patients did not receive adjuvant CDK4/6 inhibition, given some of the concern about toxicity of IO with, for instance, abemaciclib. In this study, the majority of patients had a CPS that was 1% or greater. If 10% or greater, it's about what we see in triple negative breast cancer, about 40%. The majority of patients had node positive disease, and also the majority had an ER positivity of 10% or greater. So what I'm showing you here are those patients who had lymph node positive disease and those who had lymph node negative disease, and you can see that higher rate of PCR was observed in those patients who had lymph node positive disease, but again, this was a higher risk population. The other thing that was seen similar to the NEVO study that I just showed is that for those patients who had PD-L1 positivity, that seemed to be an indicator for PCR. Also noting those patients who had CPS of 1% or greater, we're already seeing an improvement of PCR for about 10%. And this is just looking at ER expression and response in those patients who had low ER expression, meaning less than 10%. That delta, when you added in IO, was about 24%. It was about 10%. Again, this is an exploratory analysis. The majority of patients had high ER positivity. But if we think of the implications of this in clinic now, to me, the big take-home point from this is that if you have a patient who's a low ER expressor, that 1 to 10%, before sometimes I had a hard time getting IO for these patients. Since these data were presented, now we have randomized data in terms of the improvement of PCR, but we are still awaiting event-free survival data. The other thing I want to mention before we talk about chemo is just, there's an ongoing SWOG study, 2206. There had been some data that had been published by Lajos Pucai and the iSpy group that had demonstrated utilizing MammaPrint, the 70-gene assay, for those patients who had MammaPrint high 2, that there seemed to be an added benefit of giving IO. And there's a difference in the biology for those ER-positive tumors that are MammaPrint high 2 compared to high 1. The high 1s are more estrogen-driven. These seem to be more IO-driven. And in this population, patients are being randomized to chemo with or without durva. So this is really trying to discriminate the ER-positive patients that may benefit from IO. So we've talked about the responder study. This was a study of about 5,000 patients with hormone receptor positive, HER2 negative disease with 1 to 3 nodes involved. And if the recurrence score was 0 to 25, patients were randomized to chemo followed by endocrine therapy versus endocrine therapy alone. For those patients who had a high recurrence score, greater than 25, they were recommended to receive chemotherapy. We do have funding now to go back and look at this population and see what their risk was. So that's those are data to come sometime in the future. We have not reported that yet. But one of the other things just to highlight about this study, as Virginia already mentioned, few patients had T3 disease, only 5%. Less than 10% of patients had 3 nodes involved, and very few, 3%, were less than 40 years of age. And there's some points that I really just wanted to reiterate. Postmenopausal patients, as we've already discussed, the question is, what about if you have more than 3 lymph nodes involved? And the major question from this study, about a third of patients were premenopausal. And we saw in this study that regardless of recurrence score, if it was 0 to 25, patients were benefiting from chemotherapy. The question is, given the fact that ovarian function suppression was low in this study, is it because the biology is different in premenopausal patients where they benefit more from chemo? Is it a direct effect? Is the tumor biology different in someone who's premenopausal versus postmenopausal? Or is it strictly due to the fact that patients are no longer having periods when we give them chemo? I do want to mention for node-negative disease, we have the RS-Clin tool, which is available in the US, and I want to make 3 points. One, it is not just the score itself, it is the incorporation of clinical features, which also helps individualize risk. So you can go online, you can put in these features, have an individualized distant recurrence risk at 10 years, an individualized benefit. The other thing that came out of San Antonio is that there's also a new tab in there that is looking at years 5 to 10 and letting you know, if you put in the features, including the oncotype score, what is the risk from years 5 to 10? It gives you a prognostic output. The other thing that I just want to mention, these were some data that were presented at ASCO last year from the SOFT-TEX trial that looked at the patients who were less than 40 years of age compared to those who were greater than or equal to 40 years of age. Those who were less than 40 years of age had more luminal B tumors, which is demonstrated in teal, compared to those who were greater than or equal to 40 years of age. But the one thing I want to point out is if you look at that top curve, the luminal A patients, those who are less than 40 compared to those who are 40 or greater, patients still did worse if they were less than 40 years of age. And these could be biased. I don't know if the rate of ovarian function suppression was lower in these patients or not, but it is one of the things that really caught my eye from this presentation. And the other thing is, not all patients can be adherent to ovarian suppression. And we've seen in studies, including from our Asian colleagues, that about, even in randomized studies, after 2 years of ovarian function suppression, about a quarter of patients stop their ovarian function suppression. These are data, my apologies, that have led to this study. This is an ongoing study, BR009, or the OFFSET trial, which is premenopausal patients, high-risk node-negative, or that responder population, randomizing patients to ovarian function suppression plus an aromatase inhibitor with or without chemo. In the study, patients are allowed to receive CDK4/6 inhibitors, which may impact the data that we see. And then before I conclude, I just want to mention Monarch E, which we briefly talked about, and NATALEE. Monarch E included only high-risk patients, no node-negative patients, and in Monarch E, patients took 2 years of Abema. In NATALEE, patients took 3 years of Ribo. These data were published in the New England Journal of Medicine 2 days ago, but this included both intermediate and high-risk patients. But one of the things, to me, that is important about these studies is that we know in ER-positive disease that there is a risk of recurrence. About 50% of tumors recur after 5 years. And with Palbo, we did not see any carryover effect. in the Monarch E study, if patients just take those 2 years of abemaciclib, we see a benefit at 5 years. In NATALEE, the data are still early, and a good proportion of patients are completing their 3 years of ribociclib. So to me, it's important that we see the follow-up from that study. These are the data that I'm mentioning in terms of abemaciclib, which now have been updated and published, where even those 2 years of abemaciclib is giving a 5-year improvement in invasive and distant disease-free survival. These are the data with ribociclib, where you can see a hazard ratio of 0.749. Again, this included intermediate and high-risk patients. And these are the data when broken out by node negative and more than one lymph node or more disease. You can see the hazard ratio being similar between the two groups. But the one thing I just wanted to point out, including in that node negative population, that delta of benefit is about 3%. Right? And so this is the conversation that I think we'll be having with our patients. We're talking about 3 years of taking a medicine for a benefit right now that we're seeing of about 3%, and we'll see what this looks like long term.
Of course, if you're the patient, it's 100%, but we can't figure out who that patient is. So thanks so much. We're going to move on and talk about it a little bit more about breast cancer.